Thanks, O'Neill. Thank you very much, everyone, for attending today. Um, I hope that you can all hear me. I don't think it would take a lot to convince people that there's an urgent need to address mental health in the COVID context. And in fact, it's fair to say that many Canadians are feeling the stress, are feeling worried about COVID-19. And very early on in the health portfolio, it was recognized that undoubtedly COVID is likely to lead to an increased demand for mental health and substance use services in the Canadian population. It was in that context that our institute, together with 5 other CIHR Institute, Health Canada, the Public Health Agency, came together to create the COVID and Mental Health Initiative. Now, just very quickly, we've developed 3 funding streams beginning last April. I'm going to be focusing primarily on the knowledge synthesis funding stream today and what we've learned. We also developed a specific funding to develop guidance documents for people who use drugs through the Canadian Research Initiative in Substance Misuse. And I'm going to allude at the end to 55 operating grants on substance use service needs and delivery that are currently in place and are the knowledge of which will be mobilized this fall. So just a quick update on the knowledge synthesis timeframes for this funding opportunity. The pandemic was declared in March. In April, we developed the funding opportunity and the funds were actually out the door before the end of April for over a 6-month period. So really in the early stages of the pandemic, our investigators both synthesized knowledge, but also developed real-time knowledge that was happening as COVID was coming in its first couple of waves. And we've been mobilizing this knowledge in the first 6 months of this year. And just to let you know that we identified up to 8 priority populations ahead of this funding opportunity. And I'm pleased to say all of those populations were ultimately represented in the 45 knowledge syntheses that I'm going to describe. And they're listed here, but they really represent those who were viewed to be at significant risk for mental health challenges associated with COVID. Our knowledge mobilization plan, which we struck at the same time as the funds were being distributed, we're targeting 4 different audiences: policy and decision makers, healthcare providers and professional associations, researchers, which I'm assuming are a number of the people here today, as well as the general population. And kudos to Christy Cross, who's our knowledge mobilization leader inside our institute, for putting together this plan, part of which, as I said, I'll be discussing today. Sorry, I don't know why my slides are moving. So what we really want to talk about is what did we learn from these 45 knowledge syntheses that I can share with you today. Some of what we learned, perhaps expected, but some of what we learned was unexpected. Let's start with children, youth, and families. So perhaps not surprising, a report of worsening mental health for school-age children and youth. And of course, children with pre-existing difficulties, disabilities, or chronic illnesses were particularly negatively impacted. Social nets have been particularly beneficial. This also includes for seniors' health. So I'll come back to that later on. And in fact, surprisingly, some families actually noted positive effects because there was a reduction in daily social demands and the running around no longer possible. A recurring theme for many of the populations is that caregivers often require at least as much, if not more, support than the people that they care for. And of course, the majority of caregivers, women, and women have been disproportionately impacted during the pandemic, including their mental health. And of course, another recurring theme is the need for evidence to guide virtual delivery of mental health services, which have become dramatically increased in our populations during COVID-19. In the general population, we certainly have a history of seeing more suicide and suicidal behavior, although during COVID, it turns out that the data suggests an actual decrease in suicidal behaviors. One of the recurring themes, though, that we're learning from the general population is that, in fact, we need to take into account racialized populations and minorities that lack access to care in their own language or culture pre-COVID, and this inequity has been exacerbated during COVID-19. And that includes also individuals in persistent low socioeconomic status. So at the end of the day, we are trying to engage more of people with lived and living experience that represent all of the Canadian population, of which greater than 20% are now racialized minorities, to ensure that we actually try to bridge some of the gaps that are pre-existing in the delivery of mental health services and services for substance use. For healthcare workers, once again, I don't think it's a surprise that the impact of COVID has been significant. 80% of the Canadian health workforce are women. So once again, women disproportionately impacted. Many are young, many are single, many are in the sandwich generation where they have children that they have to care for, who are at school, or at home, I should say, rather than at school, as well as taking care of seniors in their families. So there's really an urgent need for us to up research that identifies strategies for women healthcare workers to effectively manage their mental health. Indigenous peoples and communities. I think many would likely understand that there have been and continue to be multiple social inequities for Indigenous people accessing mental health services, and these have been exacerbated by the pandemic. And the rapid conversion to telehealth or virtual delivery for Indigenous people has not yet been guided by evidence. We've learned that there are over 300 studies of internet-based CBT. Virtually none of these studies have actually been directed towards Indigenous populations or racialized minorities. Big gaps in these areas. So the other point, of course, is Indigenous ways of healing are not easily transitioned to virtual models. So it is quite important that Indigenous communities develop ways to deliver safe in-person services during the pandemic. Another recurring theme in many of the populations impacted by mental illness and substance use is that stigma is still a barrier for the acceptance of services. Stigma around mental health has improved. Stigma around substance use has not. Another area where we found that there has been something that existed before, and that is, of course, that mental illness is comorbid with individuals who have chronic illnesses or chronic pain. And of course, there's a significant number of patients who've been on wait lists owing to foregone care as a consequence of COVID. We find that virtual interventions are very effective for individuals on wait lists or with chronic diseases and chronic pain. However, patients on wait lists, which are still now on wait lists, are starting to feel very angry, are very depressed, and they're looking for peer-to-peer support. Another recurring theme that we've heard during the pandemic, and that is the need for more evidence-based peer support. And as I mentioned before, when speaking about families, we've learned that caregivers have similar levels of depression, but may actually have greater anxiety than patients when it comes to the mental health challenges associated with COVID-19. So pre-existing mental illness was perhaps one of our greatest concerns in advance of the COVID-19 pandemic. And what we learned is that even for severe mental illness like schizophrenia and psychosis, virtual interventions may in fact be effective. So while there have been reduced in-person clinical services, it's still not clear that the population understands the power of some of these virtual interventions, and this may be a communication and knowledge mobilization challenge for the future. There's also benefits to conducting remote cognitive assessments in severe mental illness. More research is needed in this area, and best practices as part of a broader research agenda have been identified as great needs to ensure that digital technologies meet the needs for those who have been particularly attuned to in-person care. Yes, of course, older adults severely impacted by the first half of the pandemic continue to be very, very negatively impacted as a consequence of isolation. And there are strategies for maintaining social connections for seniors that have been demonstrated to improve mood and cognition and reduce depression and anxiety. Once again, it's a question of being able to implement the extended social connections for seniors. And I might sound like a broken record when I say it turns out that many seniors who don't live in long-term care but live alone are women who are widowed and living alone. and in low socioeconomic status. And so they also have chronic conditions. So you can see how this can be a convergence of risk factors for mental illness. Seniors can benefit from virtual therapy, but access to technology and tech literacy can be an obstacle. So it's very important that long-term care workforce, as well as others, begin to understand how they have to bring seniors along carefully to adopt virtual care strategies. And of course, again, it's critical for us to develop better and better new ways to improve social connections in older populations, something that was an issue before COVID. And as we've heard many, many times, much of what existed before COVID has been amplified for us. So now we can better understand where the greatest needs are. So people who use drugs and substance use have suffered from what we're calling the twin pandemic. The opioid crisis has actually been exacerbated during COVID for two reasons. One, which is beyond the healthcare system's control, and that is the tainted drug supply. But there's also been a significant disruption in services for people who use drugs. And people who use drugs and their families are concerned that these voices have not been heard. And as I mentioned before, in large part because of the stigma attached to people who use drugs. And I've heard more of this in the last 3 months, even than in the beginning, because there's been an additional dramatic spike in the first quarter of 2021 in opioid deaths. The good news is that there are new models of care that are being implemented, including safe supply models, where the Health Portfolio, Health Canada in particular, in partnership with CIHR, are implementing innovative approaches to providing safe supplies to keep people away from the toxic drug supplies. Perhaps in the future, emergency preparedness will take into account, based on the voices of people who use drugs, to ensure that services are not disrupted. And of course, it's going to be critical that people understand what services can be made available during these difficult periods of time, because some services are available, but are not necessarily being taken up because of a lack of effective communication. So those who protect us the most often suffer from mental illness, including post-traumatic stress disorder. Digital psychotherapy is proven to be effective for the public safety personnel in this country. However, it's become abundantly clear that public safety personnel are really keen on peer-to-peer support. And again, the access to peer-to-peer support that's evidence-based is going to be an increasingly important element of the arsenal to combat post-traumatic stress disorder going forward. And again, as I mentioned, both for people who use drugs, public safety personnel believe that mental health care should be embedded as part of emergency response planning in the future. So our vulnerable at risk populations, in addition to those in low socioeconomic status, those who are homeless or are in very difficult financial straits, have exacerbated the problems that already exist. And one of the biggest is domestic violence and intimate partner violence. And we also have learned in the first 6 months of the pandemic that racialized populations are disproportionately impacted, and women and children in racialized population are suffering disproportionately from family violence. So it's critical as we develop strategies for the future, including post-COVID, we don't perpetuate the inequities. And that includes ensuring that those who are in low socioeconomic status or racialized populations have access to both technology and services that match their needs. So the final thing I'm just going to mention is some of the cross-cutting themes that are part of webinars that are including the webinar that was held today. So today we held a webinar that was moderated by Simone Vigod, the chair of psychiatry at Women's Hospital in Toronto, and it was focused on the disproportionate impact that COVID-19 has had on women's mental health and on substance use for women. And what came out of this today's webinar, including with the voice of people who lived and living experience, is that an increased focus on the mental health needs of women and substance use needs that are particularly unique to women must be developed in the future. And we should also understand in particular that substance use and intimate partner violence are very inextricably linked. And this is something I think that we learned from today's webinar and will be incorporated into thinking, planning to support policy and practice in the future. The next webinar we're having, which I believe is planned for sometime in June, is at the interface between the opioid pandemic and the COVID pandemic. And I think I mentioned previously that this is perhaps one of the most severe consequences of the pandemic. More people are dying from opioid overdoses today as we speak than ever before in the history of this country. And that trauma-informed care, gender and trauma-informed care is going to be an essential part of the future. And lastly, and not surprisingly, virtual delivery of services has become a thing, but it also requires evidence. And we have to be careful to ensure that the public is schooled on evidence-based digital mental health interventions. Also, we need to better understand the role, increasing role of the private sector when it comes to digital interventions and the risk, once again, for inequities to be perpetuated for people who could not access private services, which are now being championed to a significant extent in the digital health space. So a lot of work there to do to ensure that it is fair, accessible, and equitable, as it will likely become a critical part of healthcare delivery in the future. So just wanted to mention that we have a website where all this information is posted in both official languages, so you can access that information. You can also network directly with the researchers through a linkage tool, and there is a searchable repository. Lastly, I'll just mention, that, where did that go? Hold on, sorry, I had one slide left. There it is. Coming soon this fall will be the operating grants that are health services oriented, that are looking at the transformation of mental health and substance use service needs and delivery in real time. Final reports in August, and hope to be able to come back to summer all of you with that information that we seek to mobilize this fall, because it's not only relevant in the COVID context, but for the future delivery of mental health services. Sonia, I'm done. Back over to you. Thank you.
Thank you so much, Dr. Weiss. That was amazing. And we have a question so far. Right now, it's the question and answer period. We have about 10 minutes. So feel free, everyone, to either raise your hand to ask a question or ask a question in the chat box. So we'll start off with the first question, which is, what are the main barriers to accessing virtual mental health services? For example, those with low socioeconomic status. And the second question is, do we have examples of virtual mental health services that are adapted to the needs of marginalized groups?
Well, I'd say the biggest obstacle from my perspective is financial and tech literacy, but mostly financial. And I think that in a country like Canada with a social conscience, we should be considering providing the digital tools and free Wi-Fi to people who are in low socioeconomic status, as well as in racialized populations that may not have access to these technologies. And we need to start to develop focused research to serve the culturally distinct needs of marginalized populations as well as racialized populations. And we're beginning to undertake that at CIHR.
Great. So the next one is, will there be changes increased in funding related to the effective mental health interventions for racialized groups?
Absolutely. As I mentioned, it's clear that each of the racialized populations, and there are many in this country, again, it's greater than 20%, and that I'm not including indigenous populations, which are greater than 6%. So together, greater than a quarter of the population have unique cultural needs and perspectives when it comes to mental health and substance use. They need to be addressed from a prevention perspective, from a treatment perspective, and from a harm reduction perspective, let alone the perspective of the interface with the criminal justice system, where for some people, it's the first time they actually receive mental health services. So there is a dramatic need to up our game in terms of knowledge, as well as translating that knowledge to effective services for all uppercase ALL Canadians.
Great. And the next one is, how do you explain the drop in suicide? Oh, sorry, there was just a new question that came up. How do you explain the drop in suicide? Sounds counterintuitive.
Yeah, it does sound counterintuitive. Um, so, one of the things we worry about is data. And I'm not going to surprise anybody on this phone to say, the old story about great data in, great outcomes out, blankety blank data in, not so great outcomes out. So many of my colleagues suggest that we don't have a robust mental health data platform in this country. It's desperately needed. And we also need to take a mixed methods approach to ensuring that we're listening to the voices of people as opposed to assuming that our existing data strategy and statistics capture what happens in real time. It's not one versus the other, but we need something a little bit more robust and something that also captures what goes on in communities. Remember that greater than 90% of mental health services are delivered in the community, so they would not be captured by primary care or by hospital data. So we're suffering from a lack of informative data, unfortunately, although the effort is there.
All right, so next question. Can you tell us what percentage of the funding for these special programs went to early career researchers, and whether there have been any thoughts on how to provide ECRs interested in mental health with more funding opportunities?
Yeah, so I don't know that I've got that data, and I don't want to give numbers that aren't. I do know that for all the early career research programs, it's rare that the numbers funded are lower than the numbers who've applied from a percentage perspective. I know that from a male-female perspective, stated male-female perspective, it was pretty much the case. There were more women who identified as women that were funded in all of our funding opportunities. But for sure, we understand that early career researchers feel that they have been disadvantaged in some of the rapid funding opportunities. But that disadvantage also goes, of course, to women who've been at home with children. And we're trying to address all of the inequities in research funding now and into the future. But I believe that early career researchers were extremely well represented. I know that many of those who've appeared on webinars have been assistant professors, and we've just recruited 3 early career researchers to our Institute Advisory Board to keep us honest going forward, because I believe, from my own perspective, the best bang for the buck is in young investigators.
Next question is, how do you measure or create criteria for evidence-based support services in communities or groups who conceptualize mental health and wellness in various ways?
I think, again, if you take a mixed methods approach and you evaluate interventions with a framework that is there as part of the decision. So for example, right now, we are exploring an evaluation of safe drug supply with the Controlled Substances and Cannabis Branch at Health Canada for a minimum of 5 up to potentially 10 or 15 safe supply programs in communities across the country. And the evaluation framework involves both data acquisition as well as interviews. And the interviews can be dramatically tailored to ensure that communities and populations are fully represented based on the numbers within those communities, including racialized populations. We're looking for an understanding of the cultural impact as much as we are at the health outcomes in all of these studies. So a mixed methods approach is probably the best way to ensure that.
Perfect. And the next one is, what percentage of research is focused on rules specifically to better understand what works in these communities and what their needs are?
Yeah, that's a tough one, because of course rural communities are at a severe disadvantage from a distance-based access to services. But if anything, we believe that the significant improvement in the quality of evidence-based virtual delivery of care. And so I don't have an answer to that, but I can tell you that one of my colleagues, Heather, I'm sorry, I'm not going to say her last name right. It's a very long name. I'll just say Heather H., who is a researcher in internet-based and distance-based psychotherapy at the University of Regina, tells me that they, in particular, evaluate the impact of their services on rural populations as much as urban populations, and are finding that these rural populations are really starting to see the virtual delivery as a major asset and a major improvement on their ability to seek help, in particular in a crisis circumstance, where the distance and late at night, it's making a huge difference. So, but lots more to be done. And Canada in particular has quite a dramatic rural population that needs to be attended to. So it's certainly part of the work that we're doing.
So the next question, Dr. Weiss, is do you have any examples of effective online interventions to reduce stigma targeted against racialized communities in the context of COVID-19 using social media?
Yeah, that's a great question. I know that, my colleagues from the East Asian community, in particular, the Chinese community, have been asking similar questions. And I don't have an answer to it at this point, but I know that the needs, for example, of each of the racialized populations with respect to mental health have unique determinants. And particularly for the Chinese community in the context of COVID, discrimination and its impact on the mental wellness, including children and youth, has been dramatic. And the need for approaches, culturally appropriate approaches to address that, are clearly part of what would have to be focused funding opportunities going forward. And we've learned this for our expert advisory panel. If you go to the website, you'll see our expert advisory panel has great representation from racialized communities. And they've argued that you can't just lump it in to a general call. Focused calls are going to be a big part of the future.
And our final question here is, and there's a little bit of context, so I'll just read it out. Studies for COVID-19 related anxiety and depression indicate an inverse correlation with age. For example, younger people are more stressed. Also, women appear to be more anxious and depressed than men in age groups. Is this due to actual burdens carried by women or psychological differences? Also in BC, it appears that almost as many people have died from increased opiate-induced overdoses as from COVID-19 in 2020.
Yeah, so the correlation with age, I would say, we're at CIHR taking a life cycle approach to looking at all issues, including mental illness. We're particularly concerned about young people and seniors because social isolation is probably one of the biggest determinants that is causing mood issues, as opposed to the stress between the youngest and the oldest, which are more related to economic issues. When it comes to women, women clearly carry a larger psychological burden in COVID as caregivers, and this is pre-existing, but just COVID has exacerbated that, let alone that it's not clear that they've always benefited from services that are particularly targeted to the unique needs that women have. And so that's, again, a critical, important area of future research.
There's two additional questions, so we'll try to get through them. The first one is, how are you planning to enhance the involvement of social scientists in the future of mental health research?
As far as I'm concerned, social scientists are already a critical element of all mental health research, because remember that if you're going to try to understand the problem and solve it, it's a people issue. Social scientists are much better at relating to people than us biomedical types. It's not only what you ask, it's how you ask that is likely to give you the best information. And so we work very closely. And in fact, I've been of the mind, although I've been overruled repeatedly, that we should require SSHRC researchers to be part of every mental health grant. But you can see how that wouldn't go over with some of the people that feel that we shouldn't ever be that instructive. But I'm a very big proponent of the social sciences being critically important.
And final question, which is a really interesting one. You mentioned that social networks are beneficial, but what kind of social networks were beneficial, given that all of our social networks are limited these days? Virtual social networks or socially distanced visits?
Well, I think both. I think it has to do more with staying connected with the people you know and staying away from the nasty messages on anonymous social media. Sorry to be that kind of like archaic in my view, but I actually think that good social relationships with family and friends, albeit electronic or distance, are better than chat rooms, Snapchat, and the like. And that's just a personal perspective, but I think the data actually will likely back it up. I'm going to stop there.
Great. Thanks so much. This was perfect. And on behalf of the CanCOVID team and network, we would like to thank you for your time to present to us on this important topic and such terrific work that you and your team has put together. Just before we end the session, please join us for our next speaker series, which will be held next Tuesday, May 11th at 4 p.m. Eastern, to hear from Dr. Holger Schuleman and Dr. Kevin Potty on improving public and provider confidence in science through plain language summaries on COVID-19. So hope to see you all there. And thanks so much again, Dr. Weiss. Have a great day, everyone.
Take
Bye.
care. Bye.